I'm not used to using a microphone, and I'm pretty loud by nature. So if I get too loud, someone give me the like calm down Katie sign. Okay. So thank you for having me. I've actually presented in this room probably, I don't even know, 10 times over the past 6 years now. So it's a wonderful group to present to. We also spend time at the Jenks Center. We teach classes here. So you may have met Allison or Brittany. They both teach classes here. So you may have seen some of my PTs that are around. And this presentation is called Staying Steady. And the STEADI is not a spelling error. I'll tell you why. Fall prevention and safe recovery strategies for aging in place. I do, like she mentioned, I do like to take questions as they come up so I can address them as we go. And I'll try to summarize them and repeat them so everyone's on the same page. So feel free to look at me, wave, whatever you need to do to get my attention. So I got the introduction already. My clinical specialties are geriatrics, Parkinson's disease, and vestibular disorders. So while I don't treat as much as I used to, I still do a lot of the consults for our practice. So I do see patients regularly, and I mentor my clinicians and work on some of the group programming. Our practice is Healthy Aging Physical Therapy. So it's an outpatient at-home practice, which is pretty unique. So we're not a VNA. You don't have to be homebound. You can use us just like you would use any clinic that you go to downtown, wherever you may be. So we have physical therapy, occupational therapy, and wellness programs. We teach at local senior centers like the Jenks, the Arlington, Linfield, Wakefield, and we also have personal trainers that specialize in working with our populations. So we've got a lot going on. Our website's there, and I'll share that. And I did pass out, there's handouts, or they're available if you missed it. So the things I reference here will be on the handout, so you don't have to worry about writing down the links. There's also a page in the back for notes if you want to take some notes as we go. So we're going to get right to it. And I encourage you to, if you're open to it, share the following information with me and your seat neighbors here. So elephant in the room. Who has fallen in the past year? Okay, keep your hands up if you don't mind. Who feels unsteady when they're standing or walking? You can raise the other hand if you're in both. Okay, last one, keep those hands up. Who worries about falling? Thank you. That's my point. So this is a common thing, right? If we're lucky enough to get to this place where we're attending an event like this, we're probably worried about falling for good reason, okay? When you answer yes to any of these 3 questions, it's actually a validated measure to show you're at risk of falling. So this is a measure you might see in your doctor's offices. It's part of the STEADI screen. So I mentioned STEADI is not a spelling mistake. It is the CDC program called Stopping, I forgot the exact acronym. I promise you it stands for something. Basically stopping elderly accidents and disability in whatever populations. But their program has been laid out to help doctors, rehab professionals, senior centers really get comfortable at screening for falls, educating on fall prevention, and then connecting people with the right services to prevent falls. So the STEADI program is kind of woven throughout different places that you might encounter it. And we use it a lot to sort of format how we treat our patients. So you'll see me come back to it. So I don't like to spend a lot of time on the bad news, but I have to give it one slide. So 1 in 4 older adults report falls each year. Guess how many don't report the falls each year? More. So the 1 in 4 is a low estimate. Sorry, I'm losing track of my own slides here. So falls account for over 3 million ER visits. Again, not surprising. A lot of deaths. 1 in 5 causes serious injuries. And we're going to talk later about where those injuries typically occur so we can prevent them. And over 50% of older adults can't get up from the floor without help. And I'm not going to ask who here can do it or can't do it. But my advice would be if you can get on the floor, do it every day. Because if you can get on the floor once a day to stretch, to clean, whatever it is, you get that strength practiced every single day and you maintain that skill set. So if you can't do it, ask for some help and practice. And if you can do it, keep doing it. Hip fractures are the biggest problem. And I'm assuming this is not news to anybody. Can anyone take a guess as to why hip fractures are so problematic? Say it again. Well, I heard somewhere. So that's one reason why they're more likely. So someone said osteoporosis. So she said osteoporosis. So the issue is not so much the hip fracture itself, believe it or not. The hip heals, or you do surgery. The issue is that it takes a long time to recover. So after hip fracture, people tend to be out of commission for a number of months. And that reduction in activity leads to other problems. It leads to weakness. It leads to needing more help. It leads to fear of falling, which we're going to get to. So that's the big thing that we're trying to avoid when we fall. So we're going to get back to that. And most people, half of them won't get back to their prior level after a hip fracture. I won't even read the last stat. I don't like it. So how do we fall, right? 60% of falls happen at home. 40% happen outdoors. Probably not surprising. Lots of these falls happen on uneven surfaces, curbs, ice. Hopefully we're done with that for the year. Hurrying to cross the street. Nothing makes me more upset than when I've let someone go and they're scurrying across the street. And I'm like, just take your time. You don't need to run. And at home, typically it's lighting, clutter, cords, oxygen tubing, pets, slippery surfaces. We tend to fall during transition, so either getting up from something or going back down to something. Turning is a big trigger for lots of reasons, and also from distractions, right? I always say we don't fall when we're standing focused on not falling, right? We fall when we're trying to navigate our environments, the grocery, the senior center, wherever you are, and something's distracting you, whether that's a person, a place, a thing, or something internally. So internal distractions might be something like pain, having to get to the bathroom quickly, anxiety, right? You're in a very busy environment and it's anxiety provoking. So lots of reasons why we could fall. So why do we fall, right? Besides the things that happen to us. Oh, I'm pressing the wrong button. Sorry about that, guys. This is called the cycle of falling. So it really makes sense when you think about it. If we have a fall, the natural reaction is to be afraid of falling again, right? If we're afraid of falling again, we tend to avoid the thing that caused the fall in the first place, and then we tend to reduce our overall activity level. I can't tell you how many patients I've gone to and I say, have you had any falls? What do you do to prevent them? And they say, well, I don't use the stairs anymore because that's the problem, right? So now this person, well-meaning person, is no longer doing stairs, is no longer doing their laundry, is no longer getting the strength of doing the stairs, right? So it snowballs. So the inactivity causes a reduction in strength. The reduction in strength impacts how you walk. People tend to walk with less variety in their steps. And then we get an increased risk of falling and we get more falls, right? So there it goes again. So my job as an educator and a therapist is to figure out where we can intervene to stop this cycle of falling. So that's what I spend a lot of my time doing and will be doing today. So what is balance? So people typically, and I'm going to save I like to interact with the audience, but I know that I'm being recorded, so I'm not supposed to. So people tend to, when I theoretically ask what is balance, they tell me keeping your balance, holding still, right? That is just the beginning of the situation. So yes, steady state balance is holding your balance, holding your center of mass over your base of support, okay? And this changes. If my feet are together, I now have a smaller base of support, right? Standing on one leg, even smaller. So that's the beginning of balance. But more importantly, balance has to do with movement. So if I tell you all to stand up, and feel free to try this. I like people moving. Anyone want to stand up and try this? Okay. Pretend like I'm about to throw a ball at you. What did everyone do with their bodies to get ready to catch the ball? Everyone got a little lower, right? So you can sit back down. So that's called anticipatory balance. If I'm going to walk on ice, what do? Just cruise right along? No, right? I like get a little wider, I slow down. So our bodies know what to do to prevent a fall, and we naturally do it, right? We catch the ball, we get strong. So that's anticipatory balance. And then we have compensatory postural adjustments. That's what the CPA stands for. So that's what we do if we lose our balance. If that center of mass goes so far past our space of support that we have to do something to respond. So I'm going to make you do something else for me. So balance is 3 parts: steady state, anticipatory, and compensatory. All right, so we're going to back on our feet here for a minute. Whoopsies. All right. Again, totally voluntary. Don't do anything you're not comfortable with. Feel free to hold onto the chair in front of you. So steady state is simply working on standing and holding still. So bring your feet together. Now you're challenging your steady state balance. Everyone with me? Anticipatory, catching that ball. We got low. Compensatory, this is the fun part, is either using your heels, kind of rocking back and forth a little bit, right? So imagine a wind comes and you go, whoop, that's all it is. That's your first reaction. Now I want you to get close to your chairs, get ready to sit, but stop short of the chair. Good. That is your trunk strategy, right? We get low. That's like the ice. You slip and you're like, whoop, almost fell, but I didn't. Okay? And the third one, I don't want you to do this because we're too close quarters here. You can sit back down, is when you have come so far past that base of support that the only thing left to do to avoid going to the floor is take a step. Okay? So we step in all directions wherever we have to prevent the fall. So has anybody been to our Strong and Steady classes? I know I saw a couple people, yeah. So do you practice these in class? Yes. Because that's the way to improve your balance, is to keep practicing these, okay? So I really like to teach the why before I teach like the how, because I think people understand better when you know why your body does things. Plus, I think it's really cool. So you're stuck here with me for an hour. I was told to take out all my neuroanatomy slides, but I did put it into a couple. So this is how your balance system works. We have your sensory systems, we have your brain, and we have your body, okay? And they all work together every moment of your life to keep you upright or to respond if you're heading to the floor. So your sensory system is taking in information about the world around you all day long. Your eyes are giving you visual orientation. So am I looking at the windows? Am I looking at the floor, the ceiling? All right, that's going to give me some important intel on my body position. The vestibular system is your inner ear. And unless you've had a problem with it, you probably never heard of it. And if you've had a problem with it, you probably don't like it. So your inner ear is in charge of telling you how your head is moving in space. It's telling you if it's going up and down, forward and back, and how fast, if it's rotating, if it's tilting. So when there's trouble in your vestibular system, you feel dizzy. Okay, that's why I mentioned if you know it, you probably don't like it. And then there's your skin and your joints. So the proprioception has to do with what your joints are telling you. So your knees, your ankles, when we move through the world, they're always bending. And they're telling you you're 0 degrees, 5 degrees, 10 degrees, right? They're always giving your brain that information. And your skin, in your feet primarily, is telling you what the ground feels like. Is it icy? Is it squishy? Is it slippery, right? Is it a big rug from 1940 that's high pile? So lots of different information going in all day long. Those messages all go to the brain. I am not going to go through all the different parts, but the brain's job is to make sense of it and put it together and give your body the information it needs to respond to your balance. It says you're standing upright. It says, hey, you're falling forward. Hey, you're leaning backwards. And then it tells the body, hey, you should probably step. Okay, so it gives the message down the system to step, to lean, to do the ankle thing, whatever it has to do. There's one missing piece, and it's my favorite part of the body, and that's the cerebellum. So the cerebellum compares what's going in to what's going out, and was it effective? So the cerebellum sits right back here, and it's like the AI of your brain. It's always learning from your experiences. So its job is to create some postural tone, which is how still are you? Its job is to error augment. So did I go forward too far? Oh, bring it back a little bit. Am I back too far? Bring it forward a little bit. So it's always fine-tuning your balance reactions. Your brain is doing the take a big step, and your cerebellum is going, that was a little too far there. Can you bring it back a little bit? Okay? And I tell you all this because I want to get next to what happens when we age. Okay? So you can imagine if there's a problem in any of these areas, we're going to see an impact on our balance. So when we age, we have changes with our vision, right? We lose some visual acuity. I know I'm in good company here. We all got our glasses on. We lose some contrast sensitivity. So it becomes difficult to see, especially when there's carpets versus floor changes in hospitals or hotels. They're always difficult. And we lose depth perception. That's really tricky with stairs. With the vestibular system, we lose some degeneration of the cells, so it becomes less sensitive. So we either don't sense the movement as well as we used to, or sometimes we sense too much movement, and you feel dizzy. And we also lose in the muscles some of that spindle sensitivity, so we're not getting the good information on how we're moving. And we lose some sensation in our feet, typically because of the density of the receptors. Or sometimes we have other things going on like neuropathy, diabetes that impacts our sensation. So common with, these are actually comorbidities. So those are sort of the normal things that happen to everyone no matter what we do. Then we have more frequent comorbidities in these areas, right? Health issues that come up that are more common with aging. So of course with vision we have our cataracts, glaucoma, macular degeneration, and diabetes, we often see retinopathies, so that impacts vision more. With the vestibular system, we tend to have more frequent episodes of BPPV, which is acute vertigo. We have presbyvestibulopathy, which is basically an aging vestibular system. All it means is the vestibular system getting older and you get more dizziness, and Meniere's disease. And then with, like I mentioned, neuropathy is more common in older adults, as is swelling. And swelling can also change sensation. It can actually kind of squeeze away sensation. So all in all, with the sensory system, we're not getting the messages as effectively as we used to when we age, right? Things are moving a little slower. We have trouble on curbs, uneven surfaces, in the dark, right? Because we're not able to use our vision as effectively. There's more dizziness, double vision. Oscillopsia is when you have a hard time stabilizing your gaze on the environment. And we're going to go into the other systems. So changes with the nervous system. So the nervous system is the brain and the spinal cord and the connection pathways. Okay? And I'm not going to go through a ton of this, but we have reduced volume, slower processing speeds on the highway up and down. We have more common things like stroke, ataxias, TBIs from falls, unfortunately, that sort of thing. And with the cerebellum as well, we can see more sensory ataxias. So ataxia is when you can't sense the world around you as well and you get that kind of extraneous movement. So that's that page. We'll skip through that. And with the musculoskeletal system, not surprising, we also see changes. We see lots of postural changes, right? We see a lot of forward rounding, a lot of forward head. And that isn't always just not paying attention to sitting upright. A lot of it has to do with vision, right? Imagine if you can't see as well, you're going to be always looking for the floor. So one of the best tips I can give for posture is to make sure your vision is corrected as much as possible, because then you're not having to always sort of be looking to the next surface. We see lots of development, unfortunately, of sarcopenia, which is progressive muscle wasting. So we need to really be careful about that. More common Parkinson's disease, joint replacements, all that sort of stuff. But overall, between all these systems changing, what we see in balance and balance reactions are changes in your posture, and most commonly, it's an anterior weight shift because of that posture change, right? And we talked about the steady state. My body wants to be balanced, right? Head over shoulders, over hips, over feet. But if all of a sudden I'm here, my center of mass is here. So I'm more likely to tip forward because I'm already halfway there. So that's a big problem. We also see reduced ranges of motion. So with stiffness, we get the ankles get a little stiffer, the knees get stiffer. Then we have to really over-rely on quick stepping, right? Because our ankles don't do their job anymore as well as they should. And unfortunately, we also have reduced muscle power. So we lose some of the strength and quickness in our muscles, so that quick stepping also becomes harder. There tends to be more pain. With all these conditions, we tend to have more pain. So that can impact someone's ability to tolerate weight on their legs. And we see changes in your walking. So we tend to walk slower. And believe it or not, your brain is very automatic with walking, right? For years and years and years, and probably most people still now, can walk without thinking about it, right? Because your brain has a reflex that just says go. When walking becomes slower, we can't rely on that reflex, and it becomes more effortful. We have to think about each step we're taking. And if you're thinking about walking, then your attention is divided, and you're not as good at dealing with distractions that come up. Does that make sense? Okay. So I like to get all the bad stuff out of the way, and now we're going to get into how to prevent falls, because I know that's why everyone's here. No one actually wanted to learn all about this in the first place, but now we're moving on. So I brought up this STEADI program because the STEADI program has a wonderful 6-pillar approach to fall prevention. So the first one is screening. So you should, at your regular wellness visit with your doctor, they should be screening for falls. They should be asking you some questions. They might have you get up and walk. They might have you do a sit to stand test. You may have done some of this. And if you haven't, you should probably ask when you go there, be like, where's my fall screening? And if not, you can always see a PT because we love doing fall screenings. So where else am I? The other pillar is strengthening and balance training. So near and dear to my heart, very important. We're going to get into each of these with more detail. The third pillar is medication review and management. We're going to get into that. Number 4 is the vision and vestibular assessments, routinely making sure those are all up to speed. 5 is home safety modification. And number 6 is education on what to do if you do fall. So we're going to get into all that today. All right, so I mentioned screening for fall risk. So I don't expect you to read that. It's just this is the actual algorithm that your doctors probably already have. And it basically talks them through, if your patient says yes, what do I do? If they say no, what do I do? So you may get asked to do a 12-question tool, which I'll show you in a moment. You've already answered the 3 key questions when we started. Those are the STEADI questions. And they may have you do some physical assessments, like the timed up and go, the 30-second chair stand, or the 4-stage balance test, which has to do with standing in different positions. And they should be asking about risk factors. Do you have a safe home environment? How's your blood pressure? How's your vision? So a good doctor will be poking a little bit to ask these things. So this is the 12, I mentioned the 12-point fall risk assessment. And it's available on the website, and I have it linked so you can find it later. But the nice thing I like about it is that for each fall risk point, it tells you why. So this can be a great place to start. So say it says, I've lost some feeling in my feet, yes or no. And if that's a yes, it's because numbness in your feet can cause stumbles and lead to falls. So it's a nice place to start. It can kind of help you self-identify what might be causing some of your unbalance or fall risk. Mm-hmm.
You just mentioned the people that will be setting up presentations.
Yeah. Yes. Yes. And I see some people taking pictures, which is great. I will smile. But if you want this, they're also going to send out the presentation later. So you'll have that. So don't worry about trying to capture everything. But I know my hair looks really good with this thing on here. I was hoping it wouldn't screw it up. Thank you. Thank you. All right. So it's strength and balance training. I love that I already know some of you come to class, right? That's fantastic. This graphic is for every adult, whether you're a solo ager, whether you're my age, whether you're Marianne's age or Suzanne's age. Every adult should be getting at least 150 minutes of moderately intense aerobic activity per week. Super important for a zillion reasons. And they should be doing muscle strengthening activities at least 2 days a week. Okay, and we're going to talk about specifically what those might look like. But this is the basic standard for anyone who wants to age in a healthy way and take care of their bodies. So those 2 resources, they'll come out with the handout. They're awesome. So that's the Move Your Way program. And there's lots of resources online for how to plan your weekly activity, what kind of exercises to do, videos, all that sort of stuff. So it takes a little of the work away. So those are great. So what to look for in strength training? So I really focus our practice and our classes on functional strength training. So functional strength training means strengthening the big muscle groups in a coordinated way so they help you do the functional things you have to do. So a squat is a sit-to-stand, is getting off the toilet, right? Is getting out of the car. So those muscles you need to do those things, which we all want to keep doing by ourselves, is a squat. So whether you're doing a squat with a barbell in a gym with a trainer, or you're simply doing sit-to-stands from home, you're doing the same thing. So you can do these things from home, here, wherever, and still get the same impact even without ever setting foot in a gym, okay? Hinges are forward hinges from the hips, and lunges are taking a lunge step. So we're not going to practice all those today, but for the arms, we're looking at pushing, like push-ups, and pulling, which is like rowing. So those are the kind of exercises that are the most beneficial as you age, both for your health in general and for fall prevention. We want to incorporate core and back strength. Really, really important for balance because that's keeping us centered. And we want to regularly include power training. So power training is moving quickly and with a lot of effort, right? So jumping is power moves, like we're jumping or hopping. Not everyone feels safe jumping. That's okay. Simply getting up and down quickly is a power exercise. So there's lots of ways to do this that don't necessarily involve like plyometrics or jumping activity. But the most important thing is to really avoid underdosing. So when you're doing strengthening activities, I want you to feel like you are working hard. And to get stronger, you have to work harder than your muscles can handle it today, okay? So when you do a set, say you're at the gym or you're in class, and if you do 10 repetitions of an exercise, and you could have a conversation with your neighbor and do 20 more, it wasn't hard enough. You really want to feel like when you finish that set, I could probably do 2 or 3 more, but I need a break. Okay, so that's how hard you want to work. And it can be difficult to figure that out on your own. So sometimes seeing a trainer, going to a gym, going to class, they can help out with that. So a quick note about osteoporosis, because odds are half of everybody in the room has it. A fall is not a problem until you actually break something, right? The fall itself, if you can get back up, it is what it is, but we worry about fractures. So conveniently, strengthening is the best way to improve your bone density too. So it's the best way to prevent falls and the best way to prevent fractures. So 2 points for strength training. The other thing that really helps bone density is impact training. So I mentioned power training. Impact training is putting some pressure through your long bones. So even if it's not jumping, doing stomping, sit-to-stands, kind of slamming your feet to the ground and standing up, marching in place, doing the stairs, those are all really helpful activities for bone building. And bone building is helpful to prevent hip fractures. And the other thing I wanted to mention is and this is not on this topic and falls in general, but while I have the room, don't be afraid of the medications. A lot of people have a lot of fears related to the medications for bone density. The risks are very small, and combined with the proper exercise approaches, it is the best way to fight osteoporosis. So just putting that out there. But the most important thing is not to be afraid of moving when you have osteoporosis. Again, we talked about the fall cycle. So many people are told they have osteoporosis and then they stop doing anything that could potentially hurt them. But that means they reduce activity, they lose strength, they have more fear of falls, and they have more falls. So it works against you. So just educate yourselves. You know, avoiding repetitive or loaded bending and twisting is the safest thing, but continuing to move as much as you can. So hip hinging, like we talked about, you know, using good back mechanics when you're lifting is really the key to staying active with osteoporosis. And you'll find if you come to the classes here, most of them are designed to be osteoporosis safe and friendly, so you're not going to see a lot of that in these classes regardless. So what to look for in balance training, okay? There's different kinds of balance programs. So there's evidence-based programs. These are programs that have been researched. They've gone through studies, they've had controls compare how they did in class versus how they didn't do in class, how many falls they had. So there's a couple of names I threw up there that are helpful to have. The Otago exercise program, Stepping On, and A Matter of Balance. Those are the ones I see most locally offered. The hospitals offer them. I'm sure they're offered here sometimes. Those have the most evidence behind them. And for the Otago in particular, we use that one all the time. It's been shown to reduce fall risk by up to 30 to 40%. So it's a great program. I can show you on the website later. We have videos of how to do it. There's also evidence-informed programs. So our class that we teach, the Strong and Steady program, is evidence-informed. I developed it based on my clinical expertise and research, but I haven't put it through trials, so I can't say it's evidence-based. But it's certainly beneficial. And then there's activities that just promote movement. So things that incorporate both postural stability and movement are going to be helpful. So I like people to choose things they want to do because they're more likely to do them. So yoga, Tai Chi, hiking, Zumba is great, tennis, pickleball, right? So common things that are offered all over the place, low cost, those are excellent for balance work. Little push for PT. It is worth considering having a physical therapist see you if you have had falls, if you're noticing near falls, or if you're just really concerned about falls, because those three things show us that you're at risk of falls, and I'd much rather see someone preventatively before they've had a fall than after, but I'm happy to see anyone at any point. That's my yoga class in Wakefield is our Halloween class doing our zombie poses, the formal yoga zombie pose. So don't forget about cardio. Couple notes about cardio. This is like your foundation. Cardio's gone through different fads, I'd say, in the last couple years, 50 years. And lately, a lot of the fitness gurus have said, you don't need it, do your strengthening, right? Cardio is your foundation. It builds capacity and resilience. So we have to start there. So low impact steady state is like walking pretty comfortably, light swimming, water jogging. You can still have a conversation. Then there's the moderate intense steady state exercise. So think about exercise where you're breaking a sweat, you're brisk walking, you are swimming laps, maybe taking a class, playing sports, that sort of thing. So that's where you're trying to get to, right? If you're not there, start with your low intensity. If you're not doing anything, start by taking a 5-minute walk. Start by marching in place for 2 minutes. It doesn't matter. You start where you are, and then you build up slowly. Ideally, everyone should be getting 150 minutes of moderately intense exercise per week. That's the guideline, the most helpful thing. There's also the high intensity exercise training, which you'll hear about, HIIT training. It's great. It's good for metabolism. It's good for diabetes. I'm not as worried about it for balance prevention, balance and falls, okay? I'm really focused on getting people to the place where they can do 150 minutes of something each week to be raising their heart rate. So the best approach, which is not surprising, do everything. If you want to live long, do aerobic exercise. If you want to live well, do strengthening. That makes sense? All right? And then if you want to not fall, don't forget to challenge your balance. And that's a quote from me. All right. Everyone doing okay? Any questions so far? Okay. So we're going to change gears a little bit and talk about fall prevention. So high-risk medications. most adults are taking medication. It's very uncommon not to be taking medications at a certain point. If you're taking 5 or more, that's considered polypharmacy. And polypharmacy itself is associated with more fall risk because there's more chance for interactions, there's more chance of having a high-risk med mixed in there. And the medications that we are most concerned about for fall risk fall into these classes. Anticonvulsants, like anti-seizure medications, antidepressants, antipsychotics, benzodiazepines, opioids, and sedatives and hypnotics. So the reason behind all of that is they make you fatigued, they can make you groggy, and they can drop your blood pressure. They all kind of have the same property. The other ones that we look out for are anticholinergics, antihistamines, blood pressure medications, and muscle relaxants. Same thing. They make you groggy, they make you a little more tired. There's some good resources here. The fall risk checklist is an easy form to fill out. And the STEADI medications linked to falls has a really more exhaustive list of like the brands, the types, so you can kind of cross-reference your own list. Now that said, I'm not telling you to go home and don't take your medications. Everyone heard me, right? What I want you to do is know what you're taking and why. So I do a lot of medication reconciliation with my patients, and I look at the list, and I can't tell you how many times people don't know why they're taking certain meds, or sometimes they're taking meds that counteract each other, like a high blood pressure medication and a low blood pressure medication. Doesn't make a whole lot of sense. This happens a lot at the hospital, and it's, you know, your PCP's been managing your meds for years. You have an episode where you pass out at home and they take you to the hospital and they give you midodrine because you had low blood pressure. All of a sudden you come home with a medication that was addressing something that happened once, and then you're taking both a low blood pressure med and a high blood pressure med. It's like, it happens a lot. So hopefully they're caught by the pharmacy, not always. So just, you should know what you're taking, who prescribed it to you, when it was prescribed to you. And it's good after a hospital stay to just bring it up to your doctor. You know, this is a new med. What, do I need it? Do I still need it? What's going on with it? Consider timing. So this is really helpful. If you take a medication that makes you feel dizzy or tired, ask if you can take it at night. I'd rather have someone take it before they go to bed, sleep well, and get up the next day and feel better than be fighting dizziness all day long, right? So talk about timing with your doctors. Stay hydrated. So most of these meds make you dehydrated. That's why they're causing falls. So stay hydrated, 6 to 8 glasses a day. And then consider non-pharmacological management techniques. Okay, this is where I love when I can work with someone and find that we're addressing some of their issues that they're using medication for. And at some point, we look at their blood pressure and it's low all of a sudden. I'm like, well, great. Exercise actually lowered your blood pressure. We can get you off this medication. And we'll call the doctor and explain, and they'll usually drop it down. So pain, if you're having chronic pain, aerobic exercise and mindfulness is super effective at dealing with chronic pain. So that's a great technique to try. Same thing with depression. They've done studies where aerobic exercise compared to antidepressants is as effective, if not more effective. Why not try it, right? You don't have to do one or the other. You might be able to cut down on a dosage if you are feeling better from the exercise. Blood pressure, aerobic exercise and strength training. It will help your blood pressure. And diabetes, strength training. A lot of people can get off of metformin if they do strength training. It can regulate your blood sugar. So important tools. That link I'll share is a drug interaction checker website. You can just write in all your meds, hit send, and it's going to tell you your interaction list. So you know if something is likely to interact. Okay. Vision and vestibular assessments. So vision assessments, just go regularly. Make sure that your glasses, your lenses are as accurate as you can possibly be. Be careful with bifocals. Okay, so bifocals are notorious for making it difficult to see depth because you have one lens telling you one thing and one lens telling you something else. So when you're on stairs and you have bifocals, sometimes it looks like the stairs are not even. So you can get progressives, so it's not as discrete, but you can also just lower them down to half, so you're only seeing the top or just put them on top of your head for a minute if you feel like you can see the stairs safely without them. Make sure you're wearing your corrective lenses if you're prescribed them, okay? Just make sure you're using them regularly. Report any changes to your doctors quickly. You know, we want to take care of our vision and our health. And another really common thing in older adults is dry eyes. So just making sure that you're using the artificial tears, because dry eyes make it foggy. So easy solution is just make sure that you keep those eyes hydrated too. And then when to seek a vestibular assessment. So most people, like I said, have never even heard of it, but if you're feeling dizzy, that's what vestibular therapists do, right? We figure out why you're dizzy and we help treat it. So we can help reduce your dizziness. So if you have acute dizziness or chronic dizziness, both are good reasons to see a vestibular specialist. If you've had an increase in near falls or falls, sometimes there's issues with the inner ear you're not even aware of. So has anyone ever had BPPV, benign paroxysmal positional vertigo? When you wake up and the world spins? Yep. It's a terrible feeling, but it's totally benign, okay? Believe it or not, there's an increased presence in older adults of people who don't feel the vertigo part. So you can have BPPV without knowing it because some people don't have the sensation of the vertigo, but it's still going to throw off your balance. So if you notice, hey, all of a sudden I am losing balance every time I turn to the right, that's a great indicator to get a vestibular assessment, because that's typically a sign that something is mismatched in the inner ear and you may or may not be able to feel it, but we can see it. So when I do this, I can actually see in people's eyes what's going on. So I can treat it without someone being able to tell me I feel vertigo. So it's kind of interesting fact. So great ways to find a vestibular specialist. There's 2 links there, vestibular.org or the AIB list. Those are a clearinghouse of providers that do vestibular work like myself. All right, home safety assessment and modification. So like I mentioned, 60% of falls happen at home. So always good to make sure your home is as safe as possible. So I'm going to just list the basics because this could be a whole talk in itself. But you want to make sure that your home is well lit and that at night you have a pathway to get from point A, the bed, to point B, the bathroom, that's lit up. Doesn't have to be a night light that stays on all night, but they make such great little stick-on motion lights. You can put them underneath the bed. I would just kind of walk the path and see along the way where you can stick them. Okay, you can use the plug-in ones. They're motion censored. They go on for 3 minutes and go off. So super easy. You want to keep your pathways clear. So easy way to do a home safety assessment for yourself is to go the places you go all day, right? You start in the morning, you sit at the dining room. Where do you go next? Walk that path to the bathroom. You know, you go to the mailbox. So everywhere that you walk throughout the day should be clear, right? Making sure there's nothing in the way, there's not wires, there's not clutter, you know, clearing the pathways. I know houses are not perfect. It's okay if you have one room that you just keep all the clutter. Just keep it out of the pathways. I'm not judging, I have the room too. But keeping stairs safe, so especially keeping stairs clutter-free, making sure rails are in good shape, and if they're not, getting rails put in, super helpful. You can always get stairless if you need to. Thinking about adding grab bars to high-risk areas. The bathroom is the most obvious one, right? Making sure there's something to hold on to when you're getting in and out of the shower. I don't love the sticky ones because they don't work, right? And if you're trusting something with your life and it lets go, we're going to have problems. So just call Natali Company. Do you guys recommend Natali Company here? Yes, we love Natali Company. They will come out and install your grab bars for you. They hard install them, they find the studs, they do it right. So it's worth having someone put in the grab bars. Keeping flooring non-slip. So PTs get a bad rap because we go in and we tell you, we hate your carpets, I want you to throw them out. I'm not that PT. I understand sometimes carpets have been there for years and years. What I do like to recommend is making sure they're not moving. So if you do your walk around and there's one carpet that always gets caught underneath your walker wheel or your shoe, that's the carpet to either tack down with a nail, use double stick tape, or get rid of that one, right? You don't have to get rid of the beautiful Victorian rug that covers your entire living room. Just think about the ones that are getting caught when you walk by them. Using caution with pets. They're well-meaning, but they get underfoot. So a great tip is to throw a little bell on the collar so you can hear them walking around when they're by you. Especially older pets, right? As the older they get, the less they hear, and they tend to not scatter as quickly. So I had an old dog, he was 17, and I fell over him so many times because I'd be cooking and he would just be right there, and I wouldn't see him and I'd back up. So just being mindful as you're aging, so are your pets. And consider a home safety eval. So we do this all the time. We go in, we spend an hour and a half poking through your house, make specific recommendations, and help you sort out, what's important to address, what's not important to address, and go that route. Yeah.
Shannon Hardy actually
Yeah.
came and presented on this.
Yes.
And it's on the WinCam YouTube site.
Oh, perfect. Yeah, so Shannon is one of our OTs, and she was here, I think, last March. Wow, it's been a year, huh? And she did a whole presentation on home safety. So that's available on the recordings on the WinCam. And the other thing I wanted to mention is, give some thought. I know we talked about aging in place as being a priority for most people, but it doesn't always make sense. So it's important to consider before you put money into modifications, is this my goal? Would I rather look at ILFs, independent living, assisted living, CCRCs before making major modifications? And most modifications are not major. They're pretty inexpensive. They're worth doing. But if you're considering, taking out a bathroom and doing some big work, it's just worth having that conversation and that thought process before committing to that. There's another 2 resources, the STEADI Check for Safety and the AARP Home Fit Guide. I'll tell you that the STEADI one is like a 1-pager, super easy to go through room by room. And the ARP one is like 17 pages. So you can choose how much time you want to spend on this project, but they're both great resources. All right, are you guys ready to giggle a little bit? Okay, so this is my favorite internet video. I'm gonna play it, and I'm gonna warn you, it's people falling. So if you don't like seeing people fall, you can close your eyes. But what I want you to look at is the people who are not falling. Okay, so you can laugh at the ones who fall, they're all fine, but keep an eye on who doesn't fall. I don't know if I can do this with this one. Let me go over here. Because what you'll see is all the balance reactions we just talked about. Oh, wait, hold on, I get the volume up. I don't know if we have volume. Sorry. Unmute. All right, you won't hear the volume, but I'll tell you, it's a dad in his car at pickup laughing hysterically at all the kids falling and going, oh, he's gonna wipe out. Yep, he wiped out. So some are gonna fall. I'm telling you, they're all fine. There's no fractures. But let's see who doesn't fall. See what happens. They slowed down. They did the wobble, right? The arm came out. Nope, wiped out. That's a hip strategy, right? So you can see them in action. These are normal reactive balance strategies. I won't play the whole thing. It's 3 minutes, but we'll see 1 or 2 more. If he turns here, he's going to drill it. Oh, it went down. So you get the idea. I will send that link. It's the most important one in the whole presentation. Okay. Oh no. Hold on 1 second. He's a very funny dad. I like this guy. Okay, so we did home safety, we did falling. So getting into, can we prevent falls? Some of them, yes. We can prevent up to 30 to 40% of falls, and we should. But in reality, we can't prevent all of them, right? If we can only prevent 30 to 40%, that leaves 60 to 70% that we're not able to prevent. So I really focus my practice on teaching fall preparedness, right? How to prepare for the worst. Because I'd rather have people not be scared, because if you're scared, you avoid things and you actually make the problem worse. So there's some science to this. So I want to talk about the different fall types. We're going to kind of go from fall prevention now to actually preparing ourselves for what happens. All right, so people tend to fall forward when they either trip, if they have weak ankles and they have a foot drop, right, that foot catches, or if they're just leaning too far forward and they don't have quick enough stepping responses, okay? People tend to fall backwards when they slip, ice, leaves, water, bathrooms. If they're backing up and just miss the chair, that's a really common one. Or if they're sitting on the bed and just slide right down. So that's really common. Sorry, I meant to tell you, when you fall forward, we typically see injuries on the arm, shoulder, face. Well, it's land first. When people fall backwards, we tend to see injuries to the spine and the sacrum. So sacral fractures, back injuries, sometimes head injuries from that, sometimes whiplash. It's a lot of back and forth when you fall backwards, so you can see whiplash. And then when we fall back laterally, sideways, it typically is from losing your balance while turning or from being bumped. So you're in a busy environment, someone gives you a nudge. And those we see, that's when we see the hip fractures. So we're really, really careful about those. So someone asked right away when I came in today, will you talk about getting up? And I absolutely will. But first I'm going to show what to do if you have a fall, because not everybody should get up every time, okay? So I teach everyone that it depends on your head to toe assessment. So you've had a fall. I want you to first do a head to toe check for any severe bleeding, any severe pain, coupled with immobility. So things are going to hurt when you have a fall. I'm more concerned if it hurts and you can't move it, right? Those are big red flags for fractures. Any numbness or tingling that wasn't there initially, of course, we're worried about spinal cord injuries. And any dizziness that may result in another fall if you get back up, right? So even though you're feeling good, if you're dizzy and you stand, I don't want you to have a second fall. So those are some things to be mindful of. So assuming you've done all that and everything checks out, then it may be appropriate to try and get back up. If you are on a blood thinner, it's really, really critical that you report falls to your doctor and or just go to urgent care or an ER to get checked, because with a blood thinner, if you hit your head, you are more likely to have what's called a subdural hematoma. So that's bleeding underneath the brain, and sometimes we don't even know what's happening until a few days later. So really important to get that checked. I threw a slide in before I started. I forgot one thing. I'm sorry, I added to my list. What if I can't get up? So this one is just for the solo agers in particular, right? Because sometimes we can't get up or we shouldn't get up. So I wanted to make a point to kind of teach you what to do. So the most obvious is call for help, right? Hopefully everyone has something they use to be able to call for help, whether it's a lifeline. Who's got lifelines? Can I do a show of hands? Show of lifelines. We got some lifelines. Anyone have Apple Watches? Yes, I love Apple Watches because you can set them to automatically sense a fall, so you don't even have to call, right? They'll just call your person if you need to, or call 911. You can set it. Amazon Echoes or the home listening devices are awesome because even if you can't get there, you can say to it, call, if I say it now, everything's gonna go off, but call someone. You know what I'm talking about. And cell phones. I mean, lots of people just carry their cell phone, so making sure you have some way to call for help when you're moving around. If you can't get to a phone, you don't have one, the phone died, whatever reason, I teach a stay and wait technique, okay? Stay calm, stay warm, and stay hydrated. So if you can get to a bottle of water, if you can get to a sink, if you can get to a blanket, right? You want to just keep yourself comfortable as long as it may take to get some help. If you can get to a window, that's the best place to go, because then you can bang, wave, yell, open the window, whatever you can do to get some help, okay? The other thing that I recommend in a preventative way is if you know you're going to have a hard time getting up from a fall, and this is good habit anyway if you live alone, is to alert the local fire department that there is a solo ager, at-risk elder, disabled adult, whatever you want to call it, living at this address. And, please check on me if the case comes up. Okay, so they're always happy to keep that list. Yeah. Yeah, so she asked if someone falls and hits their head, is it an automatic call to the emergency room? It depends. If it's a blood thinner, yes. If you're on a blood thinner, yes. If you're not on a blood thinner, it really depends on so many factors. You know, if you hit your head on the dresser on the way down, but you landed on your bum, you know, that's different than falling from a ladder and hitting your head. So I think it's kind of how hard was the hit? How do you feel? I'd always defer to the PCP. So our rule as a practice is if someone hits their head, we always call the PCP for advice. So the PCP, I will tell you 9 times out of 10 will tell us, yes, send them to the ER. Yep. Yeah. So, yep. So she specifically asked about in assisted living situations when they sort of send people to the ER right away if someone has a fall. It's tricky. My mom also lives in assisted living, and it's an ongoing discussion of, you know, please call me first. Let me help you figure out what to do. But yes, they will typically, because the level of care is different, they don't have a nurse always to check it out. They have to default to having someone come check it out. I do tell people I'd rather have an EMT come out and just check you and say yay or nay. So worst case scenario, you can always have the EMTs come and they'll kind of help you figure out if it's worth it to go to the hospital. They may look at you and say, you're fine, just call your doctor, or they'll say, yeah, we should get you checked out. So EMTs are awesome. They never mind coming out. Like, when in doubt, call, I won't say the number again, it's gonna throw everything off. Mm-hmm.
Can you say more about the fire department? If you call them and alert them, like, what does that mean? What do they do?
So they have a list. So the fire department, she asked about what's up with the fire department list for people who might need some help. So they'll keep a list that if there is a fire in the house, right, they see your address come up on their scanner, they know, because you've alerted them, that someone might need additional help getting out of the house. So they're going to go look for you, right? Obviously, they're going to try to look for anyone, I would hope. But at the same time, they know specifically someone can't do the stairs. They're going to know to go, you know, to go searching more. Yep. Good thing for aging parents, too, if you're caring for aging parents, is to make that phone call. Yep.
I've made a list of links of all available services like that. Plus, on the call, I'm okay. It's like a daily check-in.
Mm-hmm.
And I'll put them out here. And there's a page you go to, and all the links will be on that webpage.
Great. Okay, wonderful. So this gentleman made a list of links of all the different services available to get some support for lifelines, that sort of thing. So that'll be available over here. Thank you for doing that. All right. So we fell. It happens. How do we fall better, right? How do we reduce risk of injury? Because falls are okay as long as we don't injure ourselves. And there's different ways to do this. So two major ways to change how you fall to reduce the risk of injury. One is change the position. So there's certain areas on your body that we consider high risk areas. The hips, the head, and the wrists, okay? So just by changing where you land to avoid landing on those areas, we can reduce the risk of fracture. The other thing we can do is change the force, right? If my whole body lands on my hip, that's going to be a lot more detrimental than if I land but then I roll, because that's going to move my weight across a different surface. So we use dispersion techniques, okay? So you'll see that's a martial arts picture. They are great at falling. So a lot of these techniques are from martial arts sciences because they're actually like professionals with this. And I work with a Muay Thai coach when I do my fall training because he is great at this. So how do we fall better specifically in these different techniques? And we're going to watch some videos. Think about football. Who watches football? I know we're out of season, but when they fall, what do? They roll and they get right back up. Right? So they are, again, experts at falling. They also wear a lot of padding. But it's a great thing to do. If you want to study falling, watch football. If we're falling forward, I'm going to put some things down so I can use my hands. So we're going to try and avoid the urge to stop the fall, with our hands, right? Everyone's instinct is to go, no, woo, and then we land on outstretched arms. And then we break something from here to here. So the better way to fall is to go like this. So if we land and disperse the force on our forearms and our hands, and just turn your head to the side, because you don't want to take face first, right? So everyone can do this. Put your hands up for a second and pretend you're going to fall. Yep, do it like 10 times. Good. So that's how to break a fall when you're falling forwards. I know it feels scary to do this when you're going to the ground, but that is the way to prevent a fracture along your arm and to your face. And a little bit of a knee bend to kind of absorb some of that and get lower. Yep, so she asked, do you have to do it over and over again to learn? So there's been research in this. There's research if teaching fall preparedness skills to older adults is effective doing it once versus doing it repeatedly. There's been actually studies on this. And they show that teaching it once is effective, not because you become an expert at doing the thing, but because it improves your balance confidence. So just being less afraid of falling improves balance confidence, decreases risk of falls. So that's a different thing. It takes about 2,000 repetitions of any new skill to learn it. So so keep going. No. So what I tell people is if you know which way you're most likely to fall. Most people, when they lose balance, can tell me, I'm going to always fall backwards. I'm always falling forwards. If you know what kind of faller you are, and you learn a technique that's going to work to reduce your risk of injury from that technique, practice that technique. And I teach my patients to do this in bed. So you can practice this on your knees in bed, going from kneeling to a fall, right? Safely. And if you did that 10 times a day or 15 times a day, every day, you would do 2,000 repetitions. So you can get the numbers. And I teach these classes all the time. People get it, and then they tell me, oh, I had a fall, but I did the right thing. So it does work. So that's the forward fall. Backwards falls, we tuck our chin, we round through the spine, and we use our arms to slap the ground. So this is a dispersion, right? I'm taking the stress away from my butt and my back and my head, and I'm spreading it out, and I sort of tuck and roll. I'm going to show you some videos, so let me just verbalize it first. And the lateral fall is like the football fall, where they're going and they thread the needle and they roll. Okay? So, do I have time to show videos? What time do I have till I'm losing track here? We're good. Okay. Back to my videos. This one's less funny, but still worth it. So, this link, which is on your handout, is my website. And at the bottom, if you scroll down, there is videos. First of all, there's resources. Remember I mentioned the Otago program? You can do it with me in my kitchen. There's also how to fall safely. So this is Sensei Josh Johnson from Martial Arts Studio in Wakefield, and he and I developed these kind of teaching videos for how to fall. So this is the backwards fall. I know there's no sound, but I'm going to talk him through it. So he's going to take a deep breath. He's going to fall backwards. There is sound. I just don't know how to use it. So if you do it at home, you can see the sound. He's falling. He's going to bend his knees. He's going to tuck his chin. And he's going to splat. But that doesn't look too bad, right? Let me see if I can play it again just from that part. So he tucks his head. I don't think I hit play. So you can do this sitting at the edge of your bed and just practice the sitting part to rolling back. Okay, so that's the falling backwards fall. This one is the face forward one I mentioned. Let me see, because I know I don't want to waste too much time here. Let me see if I can fast forward. Okay, so he's talking about not putting your hands straight, but turning your head to the side, using your forearms to break the fall. And this is what I mentioned, like being in bed. You can do this kneeling on your bed if you feel safe, or have a PT working out with you, even better. Okay, so his head never hit. He spread the force out with his forearms. Yep, And I'll show you his standing version too, just so you can see both. I can actually play both because there's no volume. So my left side videos are like the beginner, like do it from the floor videos. The right side is what it looks like from standing. And when we do these classes, we do them on the mat, so you're not doing this on the hard floor. And I have Josh demo. I'm like, just watch him do it. So that's how not to do it. That was the don't do it one. But now he's going to show you how to do it properly. He is incredibly durable. See? So it hurts. I mean, you're going to be sore, but you're less likely to fracture your arms. So, and this one, I'm going to show you the sideways one. Let me see if I can speed things up a little bit. So he's going to show you how to kind of thread the needle, we call it. So he's threading the needle, you're going down, and you end up kind of rolling. Yep. So it takes the strain off of the hip, and you end up basically in a backwards fall. I'm going to hit the other one too, get that one going. Yep. So you end up rolling. Okay. So these are on the website. You can watch them at home. You can show your friends. They're free. What's that? The thread the needle one? Oh, I didn't bring my mat today. She asked if I could throw myself to the ground for you guys. So I cannot, but good news is we're actually going to bring some fall preparedness classes here. So more information coming. There's going to be some Saturday, you got to get up on a Saturday with me, classes. I'm not going to play these right now, but there are some videos here too about getting up from a fall. Okay, so this one shows you how to do it on your own, and this one shows you how to do it with someone helping you. Okay, so those are here for reference on my website. Let me get back into this. Give me 1 second.
So a lot of these falls look like the way children fall.
Yeah.
Naturally.
Yeah. So she said a lot of the falls look like how children fall naturally. So mobility is innate, right? And children do things by reflex. So if you notice a toddler learning to walk, what do? They get low. They use their balance reactions because they know they're going to fall. So their bodies are like, well, don't stand up too straight yet. So they know what to do. So when someone has had a stroke or a brain injury, we use what's called developmental postures to train mobility again, because your body learns best when we do things that are familiar. So we do things that are basically what you learned as a child. Yep. All right, so common themes to fall better. If you don't remember each specific fall, remember this. Don't freeze, okay? Try and relax your body. It's so counterintuitive, but the best thing you can do for yourself is to get soft, okay? Because if you get soft, you round and you roll. If you get rigid and terrified, you go like this and you land in a really dangerous way. So you basically want to get low, avoid the straight limbs, roll with it, let yourself roll with it. It's going to help. Protect your head by tucking your chin and land on the meat. So the meat is your bum, okay? So nice and thick. Good place to land, avoiding the sides, land on the meat, okay? And those are common themes in all of those. So I want to wrap up and leave a few minutes for questions, just to give you a sense of what we offer. So I love teaching. We teach class here on Mondays and Thursdays. We teach our Strong and Steady class. So it's mostly fitness and some education woven in. And then we're going to be teaching some, like I said, actual skills practice for falling techniques starting in the summer. Yep. So these, right here, perfect. Yep. So we teach Strong and Steady here. We also teach in Arlington, and it's starting in Melrose. And I mentioned our Fit and Fearless program is really cool. So this is the defensive edge in Wakefield. We've taught classes there about falling safely and some adaptive martial arts. We also do intensives, so you can come in and work with us one-to-one and learn these skills. Couple pictures of it. It's pretty fun. Yep, that's the class we teach. That's our coach Dave, who will grapple. He'll have people actually grapple. It's really cool. And I'll finish on this page so you have my information. But I think did I make it on time? We have 5 minutes for questions, 10 minutes?
Yep.
All right. Thank you guys for being patient while I went through my 1,000 slides. My pleasure. Any questions about balance, falls, home safety, other things? Yeah.
That's about my mother again. She has dementia and she falls a lot. How can physical therapy with the baby's brain with the back?
Yeah. So she asked how physical therapy can help someone with dementia prevent falls in particular. So we think of physical therapy and occupational therapy in 2 ways. Restorative, what can we fix? And compensatory, what can we compensate for? So oftentimes with dementia, there's some things we can fix, right? We can get people stronger. We can work on walking. We can work on balance. And some of that can improve. But a lot of it has to do with what can we compensate for, right? What can we educate the caregiver? What can we do to reduce fall risk around the house, right? What can we protect around the person? What can we do at night to prevent falls at night? Should we put in a monitoring system? Should we use, put a mattress on the floor? There's lots of things we can do to compensate for the fall risk. I love this example. Someone had a loved one who kept going down the basement stairs, and it was driving them crazy because they kept falling. So what they did was they put a mirror on the door. And it was enough to tell the person, it just took away the impulse of using the stairs. I'm like, what a genius thing. So there's lots of things we can do to the environment to improve the safety for someone with dementia. Yeah. Do you have a question in the front? Yeah.
Yeah, 2 things. You said you put 6 to 8 glasses of water.
Mm-hmm.
Is that an 8-ounce glass?
That's a good question. So I wouldn't worry about the size of the glass. So in general, when we talk about staying hydrated, if you want the real number, it's half your body weight in ounces per day. That's the technical number of what you should be drinking per day. And everyone weighs different amounts, so the glass size is kind of moot. The other way, I'm not a stickler for numbers, probably because I'm really bad with math, so I just by nature don't like to do it, but is to drink until your pee is pale yellow. Seriously, it's really clear. Like if your pee is really concentrated and bright orange, you're dehydrated. If your pee is clear yellow, you're in good shape. If it's clear, you're probably overhydrated. So if it's another color, you should call your doctor. Yep.
One tip I have is only for men, but when you get up to go to the bathroom in the middle of the night, have one of those little urinal bottles.
Yes.
Pee in that and jump back to bed.
Yes, so he suggested for men in particular. Actually, I'll jump off on this. So having a bedside urinal can be really helpful. 1, because you don't have to walk anywhere, but 2, because you don't have to actually wake up enough to go walk, right? Because if you have to walk to the bathroom, then you're already awake and it interrupts your sleep cycle. So sometimes I recommend the urinals. For women, they have the PureWick now, which is so much better than it used to be. So if you're really having trouble at night with incontinence, or someone else that you know they have a system called the PureWick. So it's internal, but it drains the urine. It's not a Foley catheter. It's not like you have to have a nurse put it in. It's really pretty straightforward. PureWick, P-U-R-E-W-I-C-K, PureWick. And they might have a male version too. The male version we typically refer to as called a condom catheter. So lots of different options for overnight incontinence. Yep.
You mentioned a company locally that installs the grab bar.
Yes.
In favor. What was the name?
Yes, she asked about a local company for grab bar installation. It's called Safety Care. They go by 2 names, Natali Company and Safety Care. Yep, N-A-T-H-A-L-E, Natali Company, or Safety Care. It's actually the same company. It's John Natali is the owner. They're in Woburn, I think. But they are just nice people, and it's not just grab bars. They have all the different accessibility stuff. Yep. Yep, in the back.
I just heard about this thing called the Epley method.
Epley maneuver.
With vertigo.
Yep.
Could you, comment on whether it's a thing or
Yeah.
just?
So it's a great question. So we asked what the Epley maneuver for vertigo is. So I mentioned BPPV. So BPPV is called benign paroxysmal positional vertigo. And what happens is the inner ear has 6 different canals, okay? So in these canals, there's fluid. And in the fluid, there's tiny little calcium carbonate crystals. And they're teensy tiny, you know, you can't even see them. But what happens is that they move around the canals, and that's how your body knows where it's moving in space. Like I mentioned, it can tell your movements. So what BPPV is those crystals get dislodged and they get stuck in the canal. They're supposed to slide through, go back into where they live, and then go back around. If they get stuck, it tells your inner ear that it's moving when it's not. So when you roll over, one side's going to go, you're moving, 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 and you get vertigo, okay? So the Epley maneuver is a maneuver we do to literally reposition the canals and the crystals to get the crystals back and to dump where they're supposed to be. So it is a really effective maneuver if it's done in the right plane, for the right canal, for the right diagnosis. So here's the problem. YouTube has videos of Epley maneuvers, and there's 6 canals. So the Epley maneuver for the right side only works for the right posterior canal, but there's also the right anterior and the right horizontal canal. So if your crystals are in the other canal, you actually can make it worse because you're moving it in the wrong direction.
So don't do this at home.
So please don't do the Epley maneuver at home. But I do Epleys all the time. There's also different maneuvers. So basically when I go out to see someone, I put you in different positions to see which canal it is, and then I do the right maneuver for your type of canal. Yes. Yep, I do those. Great question. Yep, in the back.
Changing my bathtub to a shower.
Okay.
A walk-in shower. What are safety-wise? What are the things that I need to do?
Great question. So she's changing her bathtub to a walk-in shower, which is always a great idea. Because bathtubs are difficult to step in and over, you know, there's that thing. So in terms of safety for a walk-in shower, I think if you have the chance to build in a seat, go for it, you know, so you don't have to have other equipment in there. And I would have them hard install a grab bar in the wall across from, so say you're walking in right here, I like a grab bar over here. So if the seat is here, the grab bar is here. And sometimes I like a grab bar, depending on people's needs, a vertical grab bar in the entryway of the shower. That way you're not holding onto the door or a towel rack. So a vertical grab bar, so you can hold on to it while you're stepping in the shower, and then a horizontal or like one of the diagonals across, so you can sit down. So this is a great point. So that strategy is called 3 points of contact. So when you're doing something that puts you at risk of falling, like getting in and out of the shower, reaching for the high cabinet, simply having 3 points of contact, 1, 2, 3, with my third hand free to do whatever I have to do, will keep you a lot safer, right? So if I'm getting in the shower, 1, 2, 3, and then I'm in. So you need to kind of plot out with your contractor when you go in where these things should be based on your position and your height. But that's great. So the floor, I think you can probably ask about a non-slip surface. I mean, I have like a rock flooring in my shower that's pretty non-slip. So I think you kind of have to feel the tile. I'm not sure if there's a specific tile type that's going to be less slippery, but I'm sure that's a good question for the contractor. And if not, they sell stickers. So you can use the non-slip bath mats. Those are fine. But they also, I love the stickers you can buy on Amazon that are non-slip stickers, because you can put them on the floor, you can put them near the toilet. They make cute little ducky ones. You can get fancy with them. Yeah, that's a great question. No problem. What other questions do we have? All right. Good. Thank you guys for coming. So the next one I think is April. Oh, and I don't think I even mentioned that. So my friend Kathy's coming in. So she's going to talk about home safety and organization. So the next one will kind of jump off on what we talked about today and help you get organized at home and reduce some clutter, some techniques there. All right, I'll turn it over back to Marianne.